My lady, good morning. Can you hear me?
I can. Good morning, Ms Carey.
Good morning. Today's witness is Mrs Helen Whately. I'd like her to be sworn, please.
Let's stand. Take the Bible and repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Please sit down.
Mrs Wakely, thank you so much for coming back to help us again. I'm sure you appreciate it's absolutely essential that we called you for this module.
Okay, no problem.
Mrs Whately, your full name, please.
Helen Olivia Bicknell Whately.
Mrs Whately, there's no rush today. Take your time. Please try and speak slowly. I'll try and do the same. A little bit by way of introduction for you. I think you, in your statement, which is INQ 587788, you set out that you've been an MP for Faversham and Mid Kent since 2015. Importantly for this module, from the 13th of February 2020 to the 16th of September 2021, you served as Minister of State for Care
Yes,
under both Mr Hancock and indeed Sir Sajid Javid as he became.
yes,
And before your time as a Member of Parliament, you worked for 8 years as a management consultant specialising in healthcare consulting, and in that role worked with NHS hospitals, mental health and community care providers. Can I ask you, in that role, did you gain any experience of the adult social care system as it was pre-2015?
in that role I was working in healthcare rather than social care.
Thank you. As I understand it, your role as Minister is not solely focused on adult social care, but social care more widely. Is that correct?
No, my role was responsibility for adult
It
social
is for adult
care.
social care.
Children's social care is focused on a different department.
Fine. Thank you very much for clarifying that.
So yes, adult social care and also then other areas including dementia, autism,
Yes.
and also NHS workforce
Thank you.
at the time.
It's probably my fault for badly phrasing it. Can I ask you at the outset for some observations, please? We heard from Dr. Jane Townsend last week that you had been on some visits with home care workers. And can you help with when that was? I don't mean a precise date, but the rough period of time.
Yeah, I mean, as a constituency MP, you get involved in all manner of issues in your constituency and want to know as much as you can about what goes on in the area. So I spent time as a constituency MP visiting social care providers, and as part of that, I went sort of on the rounds with a home care worker because I was interested to see for myself day to day what that involved.
Do you think that helped you then when you took up the post as Minister?
Yes, as an MP, you bring, and as a minister, you bring your experience to the job that you do. So having spent time, I've clearly also done visits in care homes, whether that's as a Member of Parliament or also because you have family and friends who will be receiving social care. So yes, you bring that experience to have an awareness of the front line.
Was there anything in particular that you observed during those visits, whether to care homes or to the home care sector, that really helped the way that you responded to the pandemic come March 2020 and thereafter?
I mean, my most vivid recollection from the particular home visit, series of home visits that I did pre-pandemic, was particularly the rapport between the care worker that I was with, who was called Jackie, and the people that she looked after, and how isolated many of the people that she looked after were.
We'll come on to that, I suspect, maybe in relation to visiting policies and the like. Can I start, though, before we descend to a number of topics, by asking for your really overall reflections on what you think went badly during your time as Minister, but importantly as well, what you think went well. And can you give us an overview of both of those, please?
Yes, I mean, I take it you want me to focus on the pandemic and the social care part of the pandemic, given the the module. I mean, my overarching reflection is that in a pandemic such as we experience, things are going to be really bad, and as we saw, many people will die. So the overall context is going to be horrible. And in some respects, it's like, and it certainly felt like sort of fighting a war, but the enemy is invisible, and you have no choice but to fight it. It's not that you chose to be part of that war. So that is the context. I mean, for me, as a minister, things that were particularly bad at the time was the struggle at the beginning to get PPE to social care providers. In the context of overall, there was a shortage. We knew that NHS staff who didn't have it, and therefore I was hearing from the care sector that care workers were having to care for people without PPE. Now, the PPE, as we know in retrospect, isn't perfect and doesn't always stop people catching COVID or giving COVID to anybody. But the fact that care workers were having to go to work and try and care for people without even the level of PPE that the public health team thought they should have was clearly an incredibly bad situation to be in. Another thing that I found incredibly hard, I think was a bad thing that happened, was the experience of care homes receiving patients discharged from hospital, either that were COVID positive or that they didn't know their COVID status and turned out to be COVID positive. And how, I heard at the time from some of the communications I got directly from care homes that they felt they were just being forced to take people. And in some of the stories that the inquiry has assembled in your pack of stories from the front line.
Every story matters.
Yes, that's the one. That describes care homes feeling, just somebody turning up in the middle of the night just from a hospital and being told you're taking this person, which is clearly not what should have happened. And so I think, although, and I'm sure we'll get into this more, there's the evidence about a lot of the infections in care homes probably came from just from the community, and I think it's staff bringing them in unwittingly. But that was a very bad period of the pandemic, clearly at the beginning when those discharges happened. And I think the other thing on reflection that I find very hard to think about and regret is the impact of visiting restrictions, and how for many, many months people were unable to see their loved ones, and how incredibly hard it was, particularly for somebody who had dementia or a younger person who, for instance, for learning difficulties, autism, couldn't understand why they weren't having visits from loved ones, and for whom the alternative methods like window visits and things like that often just didn't work. And also when people weren't given the chance to be with somebody at the end of life. And I think that was, that combination of visiting restrictions was incredibly hard for people, and has long-term ramifications for people personally affected.
What about something positive? What went well, Mrs. Whately?
It's an interesting you asked that. I put a note to myself on the wall in my office at the beginning of the pandemic, which was along the lines of, sort of two objectives: try to save as many lives as we can, and try to look for some silver linings out of what's going to be a really bad time. I think, and from my experience, it was extraordinary how people pulled together, whether that was people I worked with in the Department for Health and Social Care, and most obviously with Ros Roughton at the beginning, and then Michelle Dyson, who I know gave evidence yesterday, and they did an extraordinary amount of work, and all the other people around them, and my private office actually were working all hours to support me, and some of the care sector representatives who really pulled together, and people like Vic Rayner and Jane Townsend, who mentioned a moment ago, and others from the sector who, I mean, it definitely felt like people put their all in to try and get through the situation, and obviously the staff at the front line who kept working. And that was the extraordinary thing, where it was a time when people in many jobs were furloughed and able to be at home and still receive most of their income. But if you were a health or social care worker, you were having to go to work and working in places where people had COVID, and you might have been somebody who was at risk of COVID yourself, and people still went to work. I think another reflection on the experience was that sort of working together, people did things, and I feel we in government did things at extraordinary pace. The time it usually takes to legislate, to set up a new service, to do something, months and years. But within a matter of weeks, we were distributing PPE to thousands and thousands of care providers. We distributed an extraordinary number of tests, and those were processed. The vaccination programme was quite amazing. And so I do actually think that government, the NHS, local authorities, and everyone, the care sector demonstrated an extraordinary ability to do things at pace and scale in an emergency. And I think if you allow me a third thing, that social care is often seen as the underdog or Cinderella service. And for the very worst reasons that so many people died in social care. There was a period when people talked about social care. There was an extraordinary moment when Her Majesty the late Queen made talked about health and social care workers. Like, that was a real moment. Suddenly social care was in people's consciousness, and that continued for some time after the pandemic. And people realised and began to understand a bit what it was and how important it was, and actually with the unpaid carers as well. And that recognition was significant, and it enabled us in government, me, to make progress on some reforms to, for instance, improve the careers of social care workers and try and increase their status and increase the accountability, which is one of the big problems with the social care sector. And the launch of CQC assurance of local authorities is quite technical, but it's about increasing the accountability of social care, so people actually notice whether the social care in their area is good or not good, which is a long-term problem. I think I have some regret that I think the awareness of social care has probably regressed somewhat, and there's more of a focus back on the NHS. I don't want to make this political, but I see a government that's much more focused on the NHS than on social care. And I think one of the things that this inquiry can do is remind people about the importance of social care in our system. That would be a good outcome.
Well, Her Ladyship says lots of people speak about the need for recognition and the ongoing need for recognition. So what you say will no doubt resonate with other evidence we've heard. Can I go back then, please, to the start of the pandemic? And you were appointed on the 13th of February. So I'd like to ask you, please, about sort of what happened once you came into the department. And then we'll try and go through some of the chronological changes, but also talk about some of the things that you've just spoken about that perhaps didn't go so well or were more challenging. Can I start with preparedness? And if it helps you, Mrs. Whately, I'm starting at your paragraph 60. But you say there that there was obviously concerns about COVID-19 growing from February into late February, early March. And you say, I asked about the responsibilities of the department in the event that the pandemic struck and about the department's preparedness. And you say, I discovered for social care that the department and indeed the Ministry of Housing and Communities and Local Government looked to the local authorities to lead the response. So that's where I'd like to start, please. And why was it that you wanted that assurance when you first joined the department?
So I joined the department, as you said, on the 13th of February, at a point at which the pandemic was, there was a thing, there was a thing happening in China, and discussions about what would happen if it came to the UK, but the feeling was it was quite unlikely that it would come. And I had, I guess, the normal set of briefings that a minister gets when they're new to a department. So they go through all your policy areas and you have like back-to-back meetings, meeting lots of people. And I got going on the biggest objective, which was to do with 50,000 more nurses for the NHS and social care charging reforms. But I also recall saying, well, kind of what about the pandemic? What if it does come here? Clearly need to be prepared for that, and which is why I asked for and received some early briefings on the preparations being made. And I do know that even before I became a health minister, preparations were being made in the department, clearly. So it wasn't that it didn't start until I turned up. That was already going on. Do you want me to talk particularly about the local authority?
I'm going to come on
question?
to that,
Okay.
exactly, because I think you asked to see the local authority pandemic response plans. You wanted the assurance that they were going to do what they said on the tin, to put it colloquially. And I think you received 2 plans on or around the 3rd of March, which you say in your statement you did not consider them to be adequate. Can you help us with in what ways they weren't adequate?
Yes, so can I just get to sort of why I was asking local authority plans? And so I was there, and one of the things I said, well, I need to know who's responsible for what. To what extent is it my job as social care minister to make sure we are ready and have a plan, can respond to the pandemic across social care, or to what extent is it somebody else's job? And my recollection is that Ros Rout and others went away and came back with the answer to the question, which was that the social care response to the pandemic is to be led by local authorities, because that's where the responsibility lies, that the department sets policy, but oversight of delivery, operational stuff is at local authorities. That's where the pandemic plans should sit. Therefore, my question was, okay, but I want assurance. I'm not just going to go, okay, I'll take it as read, let the local authorities get on. I said I want to therefore see some of those pandemic plans. And I remember that then being incredibly difficult, that there was some delay, and I also recall getting pretty frustrated and having a conversation with Robert Jenrick around this time, because he was the Secretary of State for MHCLG, and somehow managed. I said, just get me 1 plan, 2 plans, and I was given 2 plans, and they were shocking, because there was next to nothing in those plans. I mean, if I recall right, one of them just said, well, we expect care providers to have their own pandemic plans. That was like the extent of the plan. And that was a point at which then I thought, well, okay, we need to really get motoring on the social care preparedness, clearly.
I'm going to ask about a little bit of that, please. We know, can we have up on screen, please, INQ 327767. I think you've been asked about this before in a different module, but clearly we've got different people following it. So, Mrs. Waitley, forgive me if there's occasionally some repetition with things you said in M5, but this is some WhatsApps between you and Mr. Hancock on the 3rd of March. Mm-hmm. And if we could, forgive me, just scroll down the page slightly. There you are, at 6:29 in the evening. You said, I'm chasing it. I've got hold of, I'm told, 2 LA plans from Hertfordshire and Essex. My opinion is that they are inadequate. I've asked for someone to brief me tomorrow on a plan for getting these and other plans into shape. And there are some meetings which I'll take you to that follow this. Was about to message you about my concern. You said you bumped into Rob Jenrick, who was, I think, leading at the time for MHCLG. Yeah. He has similar concerns. He's working on setting up an assurance process similar to one used for local authority Brexit no deals. And a little bit of detail you gave there to Mr. Hancock. The Essex doc says providers are required by the CQC to have plans in place to provide safe care in the event of the pandemic. And during flu, the directors of adult social services need to know the effectiveness of the provider plans, emerging risks and capacity to meet demand. That's basically it, their plan. And Mr. Hancock then asked you to put what he called some serious drive into getting them into a credible position. And we'll look at what happened thereafter. He then basically says to you, it needs a rocket under it. And I don't think you necessarily disagreed with that sentiment. I can see you nodding.
Yes.
Now, can I just ask you, do you, what role, if any, do you think the Minister of Social Care should have in making themselves assured that local authority plans are up to scratch?
Looking into the future, I mean, I think I'll take one step back from that, which is I think they're, as part of our plans for future pandemics, the country needs to know whose job is it to have the plan at what level. And you probably need multiple plans. I mean, you need a plan within a care provider. Yeah. You need a plan at a local authority level. You need a plan at the government level. And you probably need a routine oversight of that process. I mean, to me, CQC is a natural organisation given that it does lots of checking of have you got all this set of documents. CQC is an organisation that could effectively check whether providers have got plans, and now they do assurance of local authorities. They could be also checking the local authority social care pandemic plan. At a government level, the minister ought to be looking at the pandemic plan at a government level and should have some oversight. I think there is a...
Pause you there.
Yeah.
Do you mean of a departmental plan, or do you mean also of some of the local authority plans?
I would expect a minister to look to CQC to give them this is the state of the pandemic plans at local authorities, and we think that local authority X needs and YZ needs to do something about theirs, and so that would be the way I think you would work with CQC. I do think there's a challenge, though. It's easy to say with hindsight, oh well, ministers should be keeping an eye on this. The reality of our system as a minister is your job is to try and solve the biggest problems that the country most cares about in the area that is your brief, and to deliver your party's manifesto commitments, and to try and avoid crises which are very foreseeable or handle them when they're happening. And I can see that there is a risk that something like a pandemic, something that is a very bad event as it happens, but may feel at any point in time like it's probably not going to happen tomorrow. How do you stop that slipping down the to-do list of every minister, of every Secretary of State? We do have a whole department that prepares for in case we have a war, in the sense of the Ministry of Defence, but other departments are all dealing with much more the day-to-day of what's going on. And I think there is a question as like, how could you make it so that somebody felt that it was their job in government and it would be worthwhile really making sure that proper consideration had been given to things which were less, not day-to-day likely to happen, though possible, and if they happened, very bad, like pandemics.
Can I just move on a couple of days? Because shortly after that WhatsApp exchange, you were in a coronavirus, social care coronavirus meeting on the 5th of March. And to help you, Mrs. Whately, could I have up on screen effectively the readout of that? It's 609-933_4. 5th of March, we can see the participants. And there's reference there, as we've just looked at, to the two plans for Essex and Hertfordshire that you were concerned about. And if we could just scroll down a moment, JH's Jenny Harries, the assurance that you need, as in you, the minister, needed, is several layers below the plan. She told you there are hugely detailed plans sitting at local levels that may not surface. You flagged that you were concerned that perhaps these plans don't exist, but were reassured that there are plans that sit below this plan that include how do you prioritise plans. Lots of plans in there, but just to strip it back. Obviously, you wanted to look at what was under the local authority plans. Why did you get the sense that those plans might not have existed?
I don't know. I mean, I've read this in the preparation. I'm intrigued, Jenny Harris saying there are hugely detailed plans, because I never saw them. And I guess, why did I get the sense? Well, because if you ask for something and nobody will give it to you, the most obvious conclusion to reach is that it doesn't exist.
You can see Ros Roughton flagged, as we go on to page 5, that she's not sure that the current process will get to the level of detail that you necessarily wanted. She thought it was more important that we start to articulate what the sector needed to actually do. And she flagged that we may need to need local authorities to move away from containment to start on mitigating. I won't go through all of the bullets there, Mrs. Whately, but there was an idea, certainly in the middle of the page, that we'd try and find a good plan for it to be replicated and rolled out. Now, that didn't happen, did it?
Correct. So there was around this time, I don't think I was asking for a lot of detail, just some sort of plan. Anyway, there was a discussion in which, well, if local authorities haven't got plans, or many of them don't, let's find one that's got a decent plan. Surely somebody has, I've been told that they exist, and then others could work up their plan based on that as a template. That would actually save time and effort. However, no such good plan was found. And then, yes, there was a process that was intended to happen to do with reviewing plans and assurance. But actually, in practice, then things started moving very fast. The sector was desperately asking for guidance, asking for support, felt that they weren't being supported or told what to do. And there was a point, sort of sometime in around this time, that I had a conversation with Matt Hancock about this situation. And we basically said, we are going to have to grip it from the centre. Yeah. We're just going to have to do this. And it was quite almost a sliding doors moment, because I think there was a situation in which perhaps in government we could have said, no, it's local authorities' responsibility to do the pandemic response. But that was neither Matt Hancock's mindset nor my mindset. It was like, well, we're here and we should step up and do this job. I would say, because this is, it's quite negative about local authorities, actually local authorities did a huge amount during the pandemic to support care providers. And some of them were really, really good and really helped with PPE and were doing daily calls to their providers and supporting when there are staff problems and all sorts of things. But I think it is clear from this that in general they weren't ready at the beginning, and that's why we stepped up to do stuff like that.
Just a couple more points on this readout. On the fourth bullet point, there was reference there to help getting ADAS to help agree with communications, which products are needed, and a direct route of concerns from the sector through ADAS. And Ros Roughton flagged that a third of people receiving care are not known to local authorities. This is a major risk. Do you know what the third was referring to? Was it the unregulated sector or unpaid carers or both?
I don't know what exactly she was referring to, but it was true that she knew and I knew that in our landscape of social care, we clearly had residential homes, nursing homes, domiciliary care, but also unregistered providers who would not be providing personal care, because if they were, they would have to be registered, and obviously unpaid carers supporting vulnerable people, often in their households.
Right. And then just finally, at the bottom of the page there, you asked, are we thinking about the comms aspect? No one is thinking about social care preparedness or talking about it at least. And Jonathan Maron from the department said he agreed, we're not saying the right thing, we're not talking enough about social care enough. When you say by no one, did you mean in government, the department? What did you mean there, Mrs. Wade?
I think I'm talking about the communications there. I mean, clearly in government, as you can see from this conversation and other things on the record, we were thinking and working on social care preparedness. And as I said, it started before I even became a minister. I think it was more in the comms team that the comms were much more focused on whether it was on the NHS or on sort of public concerns about the pandemic, rather than communicating about social care.
Right. Now, we know that there was, in fact, no review of local authority plans. Events, as Mrs. Dyson told us yesterday, overtook us. Following that meeting, so here we are now in the 5th of March, there had been some guidance put out to the sector on the 25th of February, forgive me, yep. And then some further guidance that came out on the 13th of March. And I think in an email, certainly, that your office had forwarded an email from Mr. Hancock where someone had commented that one of the largest social care charities in the UK was very concerned about the lack of preparedness. And you were worried that the 25th of February guidance was insufficiently detailed. For example, it still said that COVID-19 was not being transmitted within the UK, and we know by the beginning of March, certainly there was evidence to suggest it was. And you asked, what are the plans for this to be updated? Mm-hmm. And I think really the question I'm asked to ask you is, that given we knew by the beginning of March there was community transmission, do you think that the 13th of March guidance should have actually been published sooner? As soon as we knew there was community transmission, we should have tried to get guidance out sooner.
I mean, I always wanted guidance to be out sooner. Everybody would want guidance to be out sooner. The fact was that it took time to produce the knowledge of COVID and how it was transmitted and what we should do about it was kind of changing on a daily basis. And there were only so many people in the Department of Health to produce guidance. I mean, there's also criticisms that guidance was updated too often, and why did we have so many iterations? And I know the department tried to strike a balance between getting guidance out promptly, but doing enough work that the guidance was worth the paper it was written on. And there had been some consultation, for instance, with the sector about whether it worked for them. So I think this is, the frustration reflects the challenge, the pace at which things were moving, and you only had so many people to, even in an expanding department as it did, to do the work.
Can I come on then to the hospital discharge policy in and around 17th, 19th of March and that period of time? Now, I think you say in your statement that you were not involved in the 19th of March discharge guidance, or indeed the NHSE letter that went to the trusts asking the trusts to expedite discharges. But did you agree with the decision to expedite hospital discharges, and if so, why?
So I understood the reasons for the NHS wanting to empty out space in hospitals. They were expecting an influx of very sick people who they wanted to be able to treat. We, I think at the time, were seeing hospitals in places like Italy having to turn away people over a certain age because they did not have beds. I could understand the NHS not wanting to do that. I also understand the clinical perspective, and I think the Chief Medical Officer is very articulate on this, that if you think the hospital is going to become an environment with COVID in it, that's also not a good place for an elderly, vulnerable person to be there at risk of catching COVID. Though I think the NHS is particularly driven by an NHS effort to free up beds ready in anticipation of arrival of a large number of patients with COVID, which I can understand. And as you said, it's clearly put out in the discharge guidance that they published on the 19th of March, that NHS England published. It would be interesting to know whether actually those discharges started happening before that date. They may have done, but it's been very hard to find data for what actually happened with discharges during that period.
Can I pause you there? Because whilst you've said that you understand the reason, I actually asked, did you agree with the policy?
So clearly I've looked at... I want to give you a straight answer. So what would have been the alternative? And the record will show that when I received later in March concerns from care homes that they were having people with COVID discharged into their care homes and sort of forced on them, and I clearly get involved, therefore, in the conversation about discharge, and the next iteration of discharge guidance, which is then published on the 2nd of April, comes past me for sign-off. And I am asking many questions, as the record shows, about whether care homes really can cope with having people discharged who have COVID into them, and what about testing, and can they isolate? And ultimately, I'm given assurance that care homes will be able to isolate safely. That is the clinical guidance that I am given. And on that basis, I kind of accept that, because I'm told, yes, care homes will be okay, it will be safe, they will be able to manage this, and also that they will be able to choose whether to accept a discharge or not. So I'm told, as part of the guidance, as the care homes can risk assess, will they be able to manage, will they be able to cope with somebody COVID positive? Now, the problem is the many stories that are out there indicate that care homes weren't given the opportunity to always do a risk assessment to check that they could isolate. They didn't always have the PPE to care for somebody safely. And it appears, in fact, that it was incredibly hard to isolate somebody effectively and stop COVID spreading in a care home once it was in there. And in fact, at the time, there was a view from our public health teams that there was no such thing as asymptomatic transmission. You were only infectious if you had symptoms. Actually, we know that not to be the case. So actually, it turned out that care homes, that they weren't safe when somebody was discharged with COVID to them. And I think if we had known those things, if that had been in the advice I was given, I would have said, look again for some alternative to this. Now, we may or may not have been able to find any alternative, because as we know, in fact, as it happened, hospitals did end up being full and people being transferred to hospitals far, far away because there were essentially no beds nearby. So there was a huge pressure on NHS beds. But still, the fact that this happened and that people were discharged to care homes and care homes being assured that it would be fine, or having no choice in the matter, that should not have happened. And I think the record shows that, and this I have a frustration with the NHS in, is that they appeared to take a view that care homes should serve the NHS in this. And you'll see, they say sort of care homes are required to do this. And my back and forth saying, no, you shouldn't require them. Care homes should be able to choose. And I think there was an attitude in the NHS at the time. And I do think this was driven from the top of the NHS. And I have read Simon Stevens' submission to this inquiry. I'm surprised he doesn't reflect on his role in this policy, because people who work for him were pushing very hard for the NHS to discharge into social care.
Can I pause you there? Because I do want to look at some of the efforts you made, particularly in the run-up to the 2nd of April guidance, voicing perhaps some of the concerns that you've just outlined. I don't want to be unfair to you then, Mrs. Whately. I'm trying to work out whether it's that you did agree with it at the time and that you regret it or have concerns about it now, given what we know, or whether you didn't agree with it as at the 19th of March. And are you able to answer that?
Well, at the 19th of March, should the NHS have discharged people into care homes, not without identifying that care homes were able to effectively isolate people. Otherwise, they were discharging somebody potentially with COVID from a hospital into and to an environment in which we know people are going to be very vulnerable. An alternative, I think, with hindsight, should have been found. And for a future pandemic, this is exactly the sort of thing that should be looked at, is what is an alternative when recognising that hospitals will, A, want to free up beds, and B, are not safe places for somebody who's frail and vulnerable. What would be an alternative?
Can I just take a step back from that, given that obviously there are these concerns? Do you think you perhaps should have been involved more in either the decision or the actual guidance of the 19th of March? Or
Yes.
not you, but the Office of the Minister of State?
I mean, yes, as I was involved in subsequent discharge guidance, because I'd started, asking what was going on. But given that NHS discharge guidance specifically referred to social care, surely they should have run it past the minister with responsibility. I think there was consultation with other people in the social care department, potential that is indicated, I think, somewhere. But in practice, clearly, I wasn't, and I don't know whether. Actually, I don't know whether that had any ministerial sign-off, that particular guidance, or whether it was entirely NHS England document.
Can I look at what happened then in the run-up to the 2nd of April guidance? And at your paragraph 95, if it helps you, Mrs. Whately, we know that in due course, the 2nd of April guidance did not advise discharged patients to be isolated, but did advise symptomatic residents to be isolated. And it included the words, all of these patients can be safely cared for in a care home if this guidance is followed, and negative tests at that time were not required before a patient was discharged from the hospital, just to try and wrap it together. You received a submission on the 25th of March highlighting how many social care providers were concerned about how the policies on discharging patients into care settings would affect their indemnity arrangements. Can you help us with what concerns had been brought to your attention, please? Is your paragraph 96, if it helps?
Yeah, I think there was a submission that was brought to my attention about this indemnity point. So I hadn't been hearing about it through other channels. There was a specific submission reflecting care providers' concerns about whether their indemnities would be valid in the event that they admitted COVID patients.
You did say that in your statement that you noted that the submission focused on care homes and did not include domiciliary care providers. Can I ask you, was there a perception that the focus was very much on care homes at this stage to the detriment of both domiciliary carers and indeed unpaid carers. Did you get a sense that the priorities were all about care homes?
I think that we were hearing from care homes at the time who were very concerned about, for instance, in that late part of March, care homes were very concerned about receiving discharges. That is not to say, however, that other parts of social care weren't considered. In fact, they very much were. And I think you can see in plenty of points of the record where we're talking about care homes, either residential nursing and domiciliary care. And in fact, around the discharge, I remember one of the conversations when I was expressing concerns about the discharge was, well, of course, the numbers going into care homes will be quite small. Most people will be discharged to home care. So home care was very much part of the early conversation.
All right, can we have a look at perhaps an email chain which sets out both your concerns about drafts of the 2nd of April guidance and indeed then the response. Could we have up on screen, please, INQ 575576, starting at _6. Thank you very much. And you'd obviously seen a draft. This is the 31st of March, 2020, yep. Mrs. Whately. You say, the Minister is concerned this is written as if the NHS is going to direct care homes to take patients, while in practice it is at the care home's discretion. And the response to you was the text has been amended to show that accepting discharges will be an ask from the NHS England, not a mandated requirement. And they give you an example on page 4, say hospitals around the country need as many beds as possible to support and treat an increasing number of COVID-19 cases. This means the NHS will seek to discharge more patients into care homes for their recovery period. Did you think that amendment, such as it was on our page 6, was clear and didn't make it clear that this was a discretion rather than a mandation?
I mean, there was a lot of back and forth about the wording. And I think, as the record shows, there was quite a level of impatience with me that I was kind of putting a spanner in the works and delaying things by pushing back on the wording. And so, as I said a moment ago, there was this very strong mindset that was coming through from the NHS that care homes needed to do what the NHS needed them to do. And I was arguing that that's not how this should work. I know that ultimately I did accept the guidance. And my biggest concern, and it's in bold in front of me, is about patients being discharged from hospital taking COVID into the care home and whether they can be effectively quarantined.
Yes.
And that, to me, is the thing that I was particularly pushing the Deputy Chief Medical Officer to advise me on whether that was really something I could be confident in. I remember a call, and unfortunately, I have tried really hard in all my submissions to base it on the written record, because clearly it's some time ago. Unfortunately, there appears to be no minute of the conversation that I know very much took place in which I was saying, hold on, every winter flu goes through care homes, norovirus goes through care homes. How can we be sure that they will be able to stop COVID going through the care homes? I'm being told, no, care homes can do this. They are used to doing this. And in effect, therefore, accepting the guidance that was then published on the 2nd of April.
You clearly, if we look at page 4 on the screen there, you've got the concerns about discharging patients into a care home. Unless it already has COVID cases, you're really concerned about this. And even with PPE, that surely materially increases the risk to others. And the response from the department was, due to capacity, care homes may need to accept patients in these circumstances. But we would expect care homes would do a risk assessment to ensure that appropriate isolation facilities are available. The DCMO was content with that advice. And then you pick up again the use of the word need. Does that really feed into your sense that there was a degree of pressure being brought to bear by the NHS to make sure that there wasn't blocks to the system and that people were discharged as quickly as possible when they were clinically able to do so? Correct.
I think there was pressure coming from the NHS. I can understand why. And the various anecdotal stories from care homes support that patient ambulances just turned up, dropping people off. So the assurance from the DCMO that they would be able to risk assess and make sure they had appropriate isolation facilities didn't appear to happen in practice.
No. Just in relation to that, obviously you are expressing your concerns here and you're receiving the advice back from the department, but do you know who was pushing back on the NHS's pressure? Aside from you, was there anyone else saying, hold on a minute, there's these implications and these ramifications?
I don't think so, in the sense of, so I was receiving the guidance. I was clearly working closely with Ros Roughton and expressing, I think, my concerns to her. I had conversations and advice from the Deputy Chief Medical Officer, who was in general providing reassurance about the safety for people being discharged, and there was the pressure from the NHS that this was needed and the right thing to do.
I think in your addendum, your lessons learned part of your statement, you make the observation that sometimes you and maybe Mr. Hancock as well were the only voices in the room speaking up for social care, trying to have to both speak to the policy but also explain the expert or the scientific advice. Do you think, whereas I suppose NHS England would have scientific or medical advisors plus the chief executive plus the COO and the like, do you think of any way there is of addressing that potential imbalance? And if so, what is the potential solution?
So yes, there was a significant imbalance, and as you saw, you'll see in the record, and it's particularly in the next iteration of the discharge advice, which I then escalate to Matt Hancock as Secretary of State, because by then we start having stories that people are actually dying, and clearly it's not working. And he, in general, was very supportive of me, and did back me to speak up for social care, or in circumstances when I wasn't in the room, I believe spoke up for social care himself. But definitely there is an imbalance. I mean, I guess it's not that surprising it's an imbalance in the sense of you look at the amount of taxpayers' money that goes on the NHS, and social care is a much less of a smaller part of the government's budget, though material. Lots of people pay for their own social care themselves, so that's not so much an area of, there is some government oversight, but it's not the same thing as the NHS, which is delivered directly with ministerial accountability. And the public sympathy for the NHS is people, the first thing, it's the number one thing that loads and loads of people care about. And so that is reflected in many situations. That, and at the beginning of the pandemic, not surprisingly, everything was like, how's the NHS going to cope? That's because the NHS is where we go when we're sick and we all worry about it. So I think it's not surprising. But yes, I certainly found, and it was quite extraordinary moments when it'd be situations, for instance, in 10 Downing Street, when there would be 5 people from the NHS and the Department, the DHSC Perm Secretary, and then me from representing social care, and I might be able to get one additional person in the room. But one time I was told, no, we can't have so many people in the room. So I had to be the only person from social care speaking. So there is that serious imbalance. I took action. That was one reason why I said quite early on in the pandemic, well, at the time I had Ros Roughton, who was the director level person for social care, and then Jonathan Marron was the Director General, and social care was part of his responsibilities. And there are meetings in which you only have Director Generals in the room. So I said, well, I think we need a Director General for social care so that somebody is there, and their number one thing and the reason why they're there in that room is because of social care. And I think Matt and the Perm Secretary very quickly, that was agreed. And actually, Ros Roughton was extremely experienced in any event as she became the Director General for social care, and then that has continued as a Director General role. I also created the role of a Chief Nurse for social care, again, to give another voice to social care. But I think there's more to do to give social care greater, some level towards parity of consideration in our system.
can we move on to the action plan, which was published on the 15th of April? And in between time, we know that there was some death data, which I'm going to deal with as a separate topic. But certainly by the 9th of April, the CQC were reporting on COVID-19 related deaths in care homes. That's just to provide some context. Can I have up on screen, please, INQ 274068. It's some more WhatsApps starting, forgive me, just let me turn up my page. And page, bottom of page 8, thank you very much. Can we see there, helpfully highlighted, this is the 13th of April, so just a couple of days before the action plan is published. And you say to Mr. Hancock, the discharge policy is my biggest concern. That's an argument with Simon, reference to Simon Stevens, I believe, clearly. Dom, possibly Dominic Raab, asked for more detail on testing and PPE are the same as mine have been for the last few days. No one seems able to give it. Can you help us now with what was your concern and what was the argument with NHS England and Simon Stevens?
Well, I mean, and it's just taking us back a minute. So on the 17th of March, there was a letter that was sent by Sir Simon Stevens out to the NHS, really pushing the importance of discharge. So that was being driven very strongly from the top of the NHS. As I say, I can understand why, if you're running the NHS, you want your beds to be freed up. But I am saying, by this point, okay, we don't have, if I recall right, sort of robust official death data, but I am hearing stories that people are dying in care homes, and care homes are very unhappy about it, and therefore I'm trying to get the discharge policy that was published on the 2nd of April updated to stop what's happening. But yeah, so this is where I have a different objective from the NHS.
I'm sorry to interrupt you. Can I ask you just to slow down a tiny fraction for the stenographer, please?
Yes.
It's my fault. I might have sped up as well, so forgive me if I did. So I interrupted you, though. You said that obviously you were hearing accounts of people dying in care homes, the unhappiness that caused to the care homes themselves. And then I sort of, I'm afraid, overspoke.
So, and this there is, and again, it's in the record, I'm sure the back and forth on the text of trying to revise that discharge policy. And that was one reason why I escalated it to Matt Hancock was that I'm trying to say, no, it can't still be written the way it was. And I keep getting these drafts coming back from the NHS where my comments have been ignored.
Right. Let's scroll down a little bit to around 9:45 that evening. And there is an entry from Mr. Hancock where he says, have you agreed a discharge policy with NHSE? Thank you very much. And you say the NHS won't keep them in an NHS setting if fit for discharge. We can't force care homes to take them if COVID infection risk. However, some may have isolation or COVID positive zones, so can. And if not, we advise local authorities to secure appropriate alternative care arrangements. For example, a local authority commissioned isolation facility, and Mr. Hancock thought that sounded messy, asked why wouldn't the NHS keep them if the alternative to having a system in place is them staying in hospital. And he told us that in what was being talked of here was potentially a proposal for not necessarily keeping the patient in hospital, but them to go into a NHS facility before moving on to the care homes as a sort of middle ground, if I may call it that, inelegantly. Is that your recollection of what this exchange is about?
Well, yeah, so I was saying, let's have an alternative. I understand that it's not a good idea for somebody to be in an acute hospital for longer than they need to, either for the sake of the individual, and we know what happens to, particularly for elderly people with long stays in hospital, and we know that the hospitals were desperate for space. So I understand that they needed to come and leave acute hospitals, but I was pushing for, well, the NHS therefore should stand up some step-down facilities as an organisation with sort of capacity, capability to do that. But as I said, the NHS was clear they would not do that. That was a hard no. And therefore, the proposal that was put to me was instead local authorities who, and it is true to say that when somebody is fit to discharge, they should be then the responsibility of the local authority to solve that problem. So the proposition was put to me that local authorities would be able to provide organised alternative accommodation. And in fact, that there were some examples of that already happening, of, for instance, local authorities kind of taking over hotels and staffing them as step-down facilities if somebody couldn't go directly to the care home where they were resident at the time. So that is the alternative that was proposed and that I ultimately accepted.
Yes,
although I think I was intrigued to hear, I think it was in Matt Hancock's evidence a little while ago, that there was a conversation in which Simon Stevens and Ros Roughton were going to handle me, which led to that decision. But there we go.
Well, leave, if we may, the internal politics to one side, although clearly not unimportant to you. I appreciate that. And by 11:30 that evening, you were asked by Mr. Hancock to write your preferred language into the doc, taking account of the NHS concerns. You say you've been working on the text. I can see the NHS point. At last, they have managed to win the battle of getting patients who are fit for discharge actually out of their hospitals. I'm asking them to go backwards on that. I think so long as it is feasible for local authorities to source provision for small numbers of COVID patients being discharged, which seems to be, for some at least, I can live with that. The important thing is that we don't force care homes to take them. Now, you've made the point about care homes feeling that they had to do it, and you heard evidence of it. Do you think perhaps now, upon the reflection, the guidance should have said, you do not have to do this, but if you have the facilities, please do it? It's never expressed that clearly in the guidance, is it, Mrs. Whately?
Yes, I think you're right. So there was back and forth and back and forth and back and forth between me and the NHS on the wording. And I would make changes and they would just disappear. I mean, it was quite extraordinary. I was kind of actually trying to write in wording. But there's... And so you asked me earlier about shouldn't guidance go out sooner. There was constant pressure to try and get guidance out. At some point, you say, OK, you accept the wording. We'd agreed an approach. However, what I think I did is I also wrote out to local authorities and others, emphasising that they didn't have to take discharge. I recall doing parallel communications about the guidance and how it should work at the time to try and stop the social care sector feeling that they had to take discharges, to make sure that this was understood at the front line, that it was their choice.
All right. I just want to clarify one of the things you just said about some of your potential wording being overwritten. Mm-hmm. Your paragraph 110, you say someone behind the scenes edits were being made that ignored my steer, and on at least one occasion my amendments were deleted and overwritten. Whether this was intentional or simply a consequence of a lapse in version control and multiple contributors to the document was unclear. However, I was frustrated with the process. Were you able to try and ascertain why it was that you as a Minister of Care were having comments overwritten?
No, it was not possible to ascertain. As I said in my evidence, I couldn't tell whether it was accidental because of all the versions or whether it was somebody writing and hoping that I wouldn't read every word to notice that what I'd put in had gone.
Do you think now that the department did enough to ensure that care homes did not feel pressured to admit patients from hospital?
As I said, I know that we did communications out to, via local authorities, and I think to hospitals as well, directly to about the process and that it shouldn't be forced on them. I think, with hindsight, you could always say, could we have done more? But people were absolutely working all hours. And I think it was around this time that there's a message that says somewhere that I'm asked to stop asking for changes in guidance because it's all too much for the staff are under too much pressure. So
yeah, we have seen an email to that effect.
Situation.
Do you think maybe that this is an example of protecting the NHS at the expense of adult social care?
So I think the NHS leadership were focused on what they needed to do for the NHS at this time. And I don't see them being concerned about what that would mean for social care.
One other topic I'd like to ask you about, and that is of the ability to isolate people once there came the guidance out saying that there should be isolation for 14 days, whether symptomatic or asymptomatic. And I think certainly in an email, you had concerns not only about forcing discharged patients on care homes, but there were care homes who said they didn't have the facilities, which anecdotally the minister has been told has happened. Are you able to give us any more detail about what you were hearing about care homes that didn't have isolation facilities?
Not necessarily. I mean, so I had all sorts of informal and formal communication channels, and clearly some of those channels are telling me that they can't isolate people and are worried about receiving discharges, but I don't think I have extra specifics on that.
Did you ever ask at all for any work to be done to ascertain how many care homes that certainly, let's say the registered ones, had the ability to isolate? I'm not talking about those that ended up in the designated setting policy later in 2020.
No, I didn't. I think so. We had established as a policy, which was that if they didn't have facilities to isolate, local authorities were going to provide alternative accommodation. I was receiving advice that local authorities were happy with that was a workable solution, that was sensible, and that was therefore the discharge plan at that time. That's how it should work. So in a world where I'm also trying to get PPE and testing and thinking about other bits of the sector as well, I think that was a point at which I accepted that was the system we had set in place.
That brings me on to PPE, Mrs. Whately. It starts at your paragraph 213 in your statement. You say there that during March 2020, you heard many concerns about the supply of PPE to social care. It included PPE shortages, local authorities not being able to get hold of PPE, concerns the NHS was being given priority over social care, and that the National Supply Disruption Response Line was overwhelmed with calls, and indeed we know that it became a 24/7 service by the 21st of March. But it's the concerns that the NHS was being prioritised, please, I'd like to ask you about firstly. And I think you asked for an update on the supply of PPE in response to your concerns. It confirmed there were the PPE shortages. The department was working with wholesalers to ensure a longer-term supply of PPE. And indeed, the update confirmed that from the 18th of March, each CQC registered care provider would be provided with the 300 face masks from the stocks available. Put the 300 masks to one side for a minute, but certainly in the run-up, on the 12th of March, you wrote in a COVID-19 senior group WhatsApp thread, there was a specific ask from social care to be given parity of access to PPE with the NHS. Recognising the response to COVID needs to be coordinated across NHS and social care system, treating it as one system. At the moment, they are worried they are an afterthought. What, if anything, prompted you? Was there a specific complaint being made to you? But what prompted you to write that the social care sector thought they were, in terms of PPE, an afterthought?
I had multiple channels through which I was receiving information from the sort of front line of social care, whether it was through my constituency office from colleagues and representatives of the care sector and others. And so through those channels, I was hearing that they felt that the NHS was getting PPE and they were really struggling.
Can I ask you, you've made the observation that clearly those treating COVID-19 patients needed PPE, but we've also got the discharge policy now, discharging patients, certainly before testing was up and running by mid-April, being discharged without knowing their COVID status and seemingly without PPE, which might provide a layer of protection. Was there anyone who was making that observation, but you're discharging them to a place where there isn't the PPE? The balance should perhaps shift to more PPE going to the adult social care sector?
I recall the battle I was fighting was for PPE, just sort of in its own right, and so my focus was to try and get to the bottom of the question of, was social care somehow losing out on the NHS getting priority, or no, was that what was going on, or was it actually just because there was such a shortage everywhere across the country that it was what was happening was a consequence of that?
All right. To give some colour to that rather bleak picture, can I ask on screen, please, INQ 327799. This is a table that was attached to an email sent to you by Lisa Lenton of the Association for Real Change on the 31st of March 2020, Mrs. Whately, and it sets out the concerns of the social care providers. And I'm not going to read through all of them, but one can see there the dates and the companies involved, and then the comments on PPE, and even just a quick scan of this page shows repeated reference to stock being requisitioned for the NHS. If we look down at the 5th of March, which is perhaps the earliest one there from DeliverNet, the manufacturer resanitisers said, used the words, NHS have, quote, commandeered the stock so it could not be supplied. And if I just go over the page onto page 2, by way of example, below the table, 30th of March, care shops say none of them would take us on as a supplier, has had concerns about not being able to fill current orders. NHS was the priority. And just the final box, please, on page 3, again at the end of March. One of the members had contacted the NHS supply chains, asked if they could access supplies for his home care agency, told no. Referred, when our members phoned the National Supply Disruption Service, they referred back to their original suppliers. Original suppliers have had stock requisitioned by the NHS supply chain, so they're stuck in a hopeless circular loop. And does that really mirror and sum up some of the difficulties that you were hearing about for the adult social care sector being able to get their hands on supplies of PPE?
So yes, the social care sector was struggling to get PPE, and obviously, and as you can see here, their normal suppliers who they would normally go to found themselves unable to supply them, often with PPE. I put this to colleagues in the Department of Health.
Yeah.
I think at the time it was Jonathan Maron who was the Director General leading on PPE, and at some point Emily Lawson. And I was told categorically no, that there was no national instruction, I think that's in the written record, there was no national instruction that the NHS should be prioritised over social care. I think there are two things going on here. I think potentially there may have been some local arrangements where maybe hospitals as quite large organisations in any area were able to get PPE directly from a supplier, and the bulk and the scale of the hospital would make it hard then for social care by comparison. I think the other thing, and this is what I was told was going on here, was that the national stockpile of PPE, which served both the NHS and social care, was indeed taking up stock or getting supplies for the national stockpile. But that was a shorthand for that was the NHS. So I was told that they think it's going to the NHS, but actually it's going to the national stockpile, which is serving health and social care.
I think you have seen results from a local government association survey which suggested that 44% of councils or care providers experience PPE being diverted to the NHS in the first 6 months, either very often or fairly often. And I just wanted to ask you about one rather severe problem that was brought to your attention. Can I have up on screen, please, INQ 327793? Here we are again at the end of March on the 27th. You've attended a call on PPE distribution. I won't go through all the bullet points, but Robert Jenrick, or certainly his office, are making you aware. I wanted to make you aware that we've heard that there is a serious issue regarding lack of PPE across Cheshire. The situation is most critical in the Warrington area. Tomorrow there'll be an emergency meeting where the council will be asked to consider shutting all council services, including 18 care homes, which require council staff to use PPE as supply levels are critically low. Across the 18 care homes, there are approximately 1,400 elderly residents. Can you help me, Mrs. Waitley? Was that an isolated example of acute pressures, or did you hear of other stories where there was potentially going to be care homes shut and many hundreds, if not into the thousands, residents needed to be rehomed?
I don't recall hearing many examples like that of services going to be shut, but I did know that many places had minimal PPE, were having to reuse PPE, were using homemade PPE or however they were sourcing it. I also knew, and I was a minister with responsibility for the NHS workforce,
yes,
that NHS hospitals were also really struggling with PPE. So I did have that context, although in general my arguments that I made were particularly on the social care side because of me being the person who was speaking up for social care in the system.
My lady, would that be a convenient moment for the mid-morning break?
Certainly, I shall return at 11:30.
Thank you. My lady, can you hear us all right?
Thank you.
Thank you. Mrs. Waitley, can we stick with PPE, please? And clearly we were looking at some difficulties there at the end of March 2020. And I think you say in your statement that on the 5th of April, paragraph 231, you messaged Mr. Hancock highlighting your concerns about PPE supply to care homes. You were finding it very difficult to get any accurate information about what supplies were available. And can we just have a look at a little bit of that exchange at INQ 274068_7. And I'll just try and pick out for you the PPE thread, as it were, because often the WhatsApps cover a multitude of topics. And we can see there at 1556, you say, FYI, the care sector is up in arms about lack of PPE. I'm struggling to get clear answers, especially for provision within the next week. The National Supply Centre is just sending them back to their suppliers who have no supplies, I'm told. I have a call with Jonathan Maron to update me tomorrow. Ros knows the situation, but want you to be aware. He says, thanks, join the PPE meeting at 4:15. You said you'd be delighted to. Who were you trying to get clear answers about the provision of PPE from?
Probably from Jonathan Maron as the point of contact for that. And I was trying to get information, I think around this time, certainly at various points of how many shipments have been sent out from the National Distribution Centre to social care? Because they're telling me, we've got it, we're doing this, but give me the data. How many, what have you done in response to the calls that you're receiving? Have you delivered to them or not? And that data was not forthcoming.
Now, can I ask you, do you know it's because the data didn't exist, or it wasn't in the right format, or there was a reluctance to give it to you? Do you know which it was, other than the fact that you just didn't get it?
I don't know which it was. I didn't get it.
Okay, and if we look down the screen a little bit later on at 5 o'clock in the afternoon, you ask Mr. Hancock, can I have someone in the supplies team dedicated to overseeing PPE to social care. It's still all over the place. They have sent me contradictory info in recent days and cannot answer questions about flow. I'm told the Clipper system looks NHS focused, and again, no one can tell me whether it will cope with 20,000 social care providers ordering stock on day one. There's only so long I can keep saying to the social care sector we're working on it without losing all credibility. Mr. Hancock says he thought that Jonathan Maron was fixing it. If not, then let's do that. Can you talk to him? And a little bit down the screen on the next day, you said, thank you for pushing Emily. Is that Emily Lawson?
Yes.
To identify an individual to oversee social care PPE. She was clearly reluctant and wants to keep the operation across health and social care. We'll see where we get to in the next few days. Do you know what the reluctance was to have a specific person dealing with PPE supplies to the social care sector?
I don't know the reason. I know Emily Lawson is an extremely competent person and dealing with clearly a very difficult situation and a huge amount of pressure from many people and places to get PPE out. But I don't know why. What we ended up doing was involving David Pearson, who was sort of partly working with the NHS at the time, but has a social care perspective, and he subsequently chaired our adult social care task force.
Yeah.
He did some work behind the scenes to make sure there was more of a voice of social care in the PPE discussion as the workaround, given that I was unable to get someone specific to social care as part of that team there.
I mean, one can understand that clearly there was a need to supply the healthcare system and indeed the social care sector, but it might be thought that there was someone wanting to keep their hands on it to ensure that the healthcare system was prioritised over the social care system, or is that perhaps reading too much into this?
I couldn't tell you if that was the reason or if there was another reason.
All right. And indeed was then a team set up to specifically oversee social care PPE. Was it just the Dave Pearson?
So David Pearson was, as I say, the sort of person behind the scenes who was there as a kind of go-to to explain how social care worked better, for instance, to people who were overseeing the PPE distribution. And then, and I refer to clearly that the Clipper system, which was emerging, and at the beginning, I felt, as I indicate there, that the people who were setting that up didn't really understand how social care worked and the complexity. I did think that by the time once that was properly up and running, it did actually do an extraordinary job of distributing a huge amount of PPE to a very large number of care providers. So once it was properly established, it was successful, but it took a while to get there.
You mentioned the Clipper system, and I'd like to ask you about that. And it's your paragraph 235 in your statement, Mrs. Whately, because there was certainly in the early stages of the Clipper system reference to the fact that the Clipper system would not be available to social care in the week of the 10th of April 2020. And there was going to be a plan to continue with drops of PPE to the local resilience fora to keep things going. Do you know why there was issues with the Clipper system?
I don't know what the delay was, no.
All right. Okay. Clearly, the drops to the LRFs were still happening. They had started in March and were ongoing. Can I ask you, please, to look at INQ on 327836? This was a submission that went to you on the 13th of April of 2020. And there'd been some LRF drops, and at the top it says, subsequent drops are expected to be needed over the next 4 weeks. Whilst the new online portal is tested and developed, we'll come back to you, and it goes through the history of the drops that have been made. And the proposal, if we can see there, is that there'll be another drop to 10 local resilience fora. They've been identified based on local intelligence, and it sets out the what's going to be in that drop. This volume will need to be agreed with the NHS on the 14th of April, but looks possible at present, and it's much smaller volume that had been sent out the preceding week. Why was there need for NHS England to agree a drop if it's essential and the LRF it really needs it?
I do not know, and whether that NHSE is a shorthand for actually the sort of oversight, because NHSE was essentially running the whole distribution across health and social care. So whether it's actually a shorthand for that or whether it's separate conversation with NHS England, I couldn't tell you from just looking at that.
Perhaps we shouldn't necessarily read into this as an example potentially of the NHS being prioritised or safeguarding their stock of PPE.
Yeah, unfortunately, it may or may not be. I can't confirm.
All right. Now, the concerns about the supplies to the adult social care sector, they persisted throughout April into May 2020. And I think certainly you then, on the 4th of May, had messaged Mr Hancock, noting that you were scheduling a conference with Lord Dayton, who was involved in PPE, and PPE wholesalers. And can we have up on screen, please, INQ 327869. This is messages between you and Mr Hancock on the 4th of May. You said you're scheduling the call with Lord Dayton, as you suggested, and with wholesalers. However, I never get helpful answers from Jonathan and Emily in those supply meetings. They are far too vague. Do you mind if next time I push harder? Could we have social care supplies as a focus for one of them? Mindful I don't want to take up too much of your time and it's your meeting. And he says we should do it properly, as it's really a question about distribution, not supply. So let's do it in a meeting. And you say, thanks. My understanding on type 2R masks is that we do have a serious supply problem, so we hardly have any to distribute, unless there's a supply solution I don't know about. It's another reference some weeks on for you not getting necessarily the answers you wanted in relation to PP. And can you help with why you weren't getting the answers and what you'd done to try and get the answers to the questions you were posing?
I'm still wanting specific figures and data. I think one of the things I was wanting to know is further into the future, what to get more line of sight of future sort of arrivals of stock, and therefore to know what was coming down the track for social care. And evidently from this, I'm not getting answers. I mean, we know, in fact, that what things that were happening was things like, you know, a plane landing and or you thought it had stock in it and it didn't, or it wasn't fit for purpose, or there were all sorts of problems, in fact, with the supply, which may explain why I didn't. But I was wanting specific answers and I wasn't getting them, clearly.
And again, do you know it's because they didn't have the data? Because, I mean, you had some data there on a supply problem potentially with the masks.
Yes, so obviously I believe I'm hearing from somebody that there is a problem with a genuine shortage of those particular masks. Like I also recall hearing at some point there was a genuine shortage with aprons that completely run out. Yeah. So, you know, I'm hearing things. But I don't know the reasons of why I didn't get clear answers, no.
In relation to masks, can I ask you about clear mask, face masks? Because clearly there was a concern that for those perhaps with hearing loss or other communication impairments, people who need and rely on reading of facial expressions and indeed lip reading, obviously a mask was an impediment to that. And I think you say you recall that in June 2020, it was recognised that people with those kinds of disabilities would require alternatives to the standard blue mask that we've been talking about. And the NHS England had procured 250,000 clear mask, transparent face masks. And you said, I wanted to be able to distribute these masks to social care. And the recommendation was to use the local resilience for that immediate supply, and then the portal for the longer term supply of the masks. Mm-hmm. And do you know, did that actually in fact happen? Was there a supply of clear masks out to adult social care sector?
So yes, we did a pilot on that. So for the reasons you say, I recognise that there were difficulties in caring for people with the traditional face mask, particularly if you had somebody who was hard of hearing. Both it's harder to hear somebody and you can't lip read clearly, and other reasons why masks a problem. So we looked at alternatives like the clear mask approach. There was a pilot, though my recollection is they didn't actually prove very popular, so it didn't become a mainstream solution to the mask need.
Do you know why they weren't very popular? Was that coming from those that were reading through them or from the care workers that were wearing them? Are you able to give us any help?
I can't. Do you know what? I'm sorry, I can't remember. Somewhere there will be an evaluation of that pilot, but I haven't seen it, so I can't remember what the reason was they weren't popular.
Can I ask you about the provision of free PPE? And in, I think, July 2020, it was proposed to introduce free distribution of PPE. And you say because you wanted a more sustainable approach to distribution. And can I ask you about your paragraph 251, please? You received a submission on free distribution. The submission noted that although we had previously maintained emergency supply of PPE to social and primary care, there was now confidence in the inbound PPE supply. DHS3 was authorised by the Treasury to purchase £14 billion worth of PPE to distribute across the health and social care system. To date, DHSC had distributed about £312 million worth of PPE to social and primary care. Can you put those sort of figures in context? I don't want anyone to run away with any misunderstanding here. Clearly, they're buying billions and billions of pounds worth of PPE, but it's actually a relatively small amount that has gone out to both the social and primary care sector. Is that because the rest of it was going to the healthcare sector?
I would need to see some analysis of whether it was that. Whether it's that already a much larger amount had gone to the healthcare sector, or was it that 14 billion, that was supply lasted for a really long time, so it was that was used for many months going forwards.
You go on in your statement to say you weren't happy with the proposal that all PPE should be provided by a single central system. Your instinct was to fund care providers to cover their additional COVID PPE costs, allow them to source from their usual wholesalers. However, the budget had already been used up for purchasing PPE centrally. Can you explain what you were talking about there and what the problem was?
I think from the initial experience with the national stockpile distribution, I was a bit sceptical about whether central distribution was the right way to meet social care's PPE needs. I didn't come into this situation with a great deal of confidence that the national approach would work for social care. However, as it says there, the PPE had already been purchased centrally, so de facto that sort of decision had in essence been made. And as I say, actually, I think the PPE portal, once it was properly up and running, did work pretty well from social care, and that's certainly what I've heard subsequently from the care sector and at the time once it's up and running. So actually that was a good decision in the end that it was done centrally.
What was the budget issue that you reference in the end of your paragraph 252? So
there was I believe, and I am having to recollect here, that the Treasury had agreed to fund a substantial quantity of PPE, but then that had already been spent on getting the PPE. So if I was going to do something separate for social care, I would have had to gone back to the Treasury and ask for additional budget in addition to that 14 billion for more PPE for social care. And that no doubt would have been a delay and a difficult process. So the budget was there that way.
I think in due course there was decisions on extending free PPE extended into March 2022. In due course. Now, Can I ask about PPE for unpaid carers? Mm-hmm. The initial advice from Public Health England and I think the DCMO in March 2020 was that unpaid carers should not use PPE. And it was based on three reasons, as I understand it. A concern that unpaid carers wouldn't be able to use the PPE properly without training, that it would be less effective for people living in the same household because they would share transmission, and there was concerns about the supply of PPE. Do you think, Mrs. Whately, that the concern that unpaid carers wouldn't be able to use PPE properly without training was somewhat unfounded, given that it was rolled out later that year, and in fact it's not incredibly difficult to don and doff a mask in the scheme of the different types of PPE there are? Was that perhaps reason being overstated in your opinion?
It is difficult for me as the recipient of advice like that to unpick. I think the question is, was the advice genuinely that unpaid carers won't be able to use PPE, or was somebody somewhere behind the scenes worried about the supply, and that was translated into advice, which is there isn't a need. That on my part, that would just be supposition. I don't have evidence that was colouring the advice I was given. The advice I was given was that the concern that it would potentially do more harm than good if you distributed PPE to unpaid carers. It might give a false sense of, I think, sort of safety, and would be inappropriate.
Clear reference was made there to PPE being less effective where unpaid carers are living in the same household. But was any thought given to the need for unpaid carers who are not living in the same household needing PPE, given they'd have to get themselves to the carer's house, they'd be going about their daily business? What thought was given to the non-resident unpaid carer?
So I think subsequently the policy that we developed when the advice in future iterations of the advice, and I think, I know I particularly prompted this being looked at again later on, because I say somewhere that I was still concerned that unpaid carers might be overlooked. So I asked for further advice on it. And then I know that there was a point at which the public health advice that then came out later on was particularly focused on unpaid carers who didn't live in the same household as the person they were caring for.
The third reason for that initial March advice was said to be a concern about PPE supply. Do you think if there had been no supply issue, unpaid carers would have been advised to use PPE in the same way that domiciliary carers were advised to use PPE?
I think that is probably a question you would need to put to the public health advisors who gave me the clinical advice on appropriate use of PPE.
I understand why you say that, and we've heard from Susan Hopkins. I suppose really what underpins that question is, was supply dictating the guidance here rather than the science dictating the guidance? Can you help with that?
And you tempt me to. I don't have any reason to give you a sort of yes/no answer to that question, because I didn't have insight into what was going on behind the scenes before advice got presented to me, and whether there were discussions about, should this colour the advice.
I don't want to tempt you or speculate, ask you to speculate either. All right. In July 2020, though, you heard concerns at your paragraph 263 that unpaid carers were not being provided with PPE. And I think there was a recommendation that month, but because transmission rates were lower, unpaid carers did not need PPE unless they were advised to wear it by a healthcare professional. And you said, although I agreed with the recommendation, I was still concerned that in local situations, unpaid carers might be overlooked. What led you to have that fear that they might be overlooked?
It's hard for me to say, given the passing of time. I think there was in this area, like in many areas, sometimes a gap between a policy that was set and worked out at the national level and the interpretation of it around the country. So that could have been the reason, and that whether it's some local authorities or some NHS areas would focus more on the needs of unpaid carers than others. That may be what is going on there.
You said, I asked to see what the formal protocol was that local authorities would consider in the event of a locally raised COVID-19 rate. The Secretary of State supported my comments. I was told that specific recommendations on what local authorities were to consider in the event of a local outbreak were not within the current remit of the Adult Social Care Winter Plan, would best be dealt with by MHCLG or the Cabinet Office's COVID team. Were you satisfied with that response, Mrs. Whately?
I was told specific on what local.
Yes, take a moment to read it to yourself if you need to.
It's a somewhat puzzling statement. Was I satisfied about in it or not? I say I can't remember the specific moment that statement was put to me, and did I do anything about it or not? I would again have to check the record. I can try and go away separate from this and see what the next step was after this. I think in general, if I wasn't satisfied about something, I did tend to do something about it. But that it's not something I can recall right now.
No, I mean, we know in due course the infection rates did rise, particularly as we got to December 2020 and Jan 2021. But in the winter of 2020, there was the trial of free PPE for extra resident carers that ended up being rolled out nationally. And can I ask you about that? Mm-hmm. And could we have on screen, please, INQ 328012. And this is from a submission that went to you on the 12th of November 2020. I think the winter plan had come out that September, if I'm correct. And it summarises there, in the winter plan, the government committed to free PPE for COVID-19s for adult social care providers, including domiciliary care. There isn't a national offer for unpaid carers, but some local authorities have chosen to provide it, including in Liverpool and Birmingham. And it makes the point that many unpaid carers are effectively doing the job of a domiciliary care worker. Reference to Carers UK's report, Caring Behind Closed Doors. And unpaid carers have been providing even more care during the pandemic, and clearly an impact on them because local services closed and they were living in poverty. So that was the sort of the background to that submission. If we go over the page to page 5, the submission noted the likely demand and made the point that data on unpaid carers was essentially an estimate. At that stage, 7.7 million. We've also heard the census reference to, I think, just under 5 million. Some estimates are higher than that. And paragraph 7 says it's unclear how many unpaid carers would take up an offer of PPE. Currently, Liverpool regularly provide 8 unpaid carers with PPE out of 52,000. And in Birmingham, where they can apply, PPE has been provided to 20 unpaid carers out of approximately 1,500 who are on their database. And they make the observation that Scotland and Wales are not doing something not dissimilar, and they've got far lower demand figures as well. Do you know, or when you were thinking about rolling out the pilot, did you ask why there was seemingly such low uptake of offers of free PPE to unpaid carers?
I expect so. I mean, a couple of things. One thing that I was certainly aware of at this time was that the records that existed about unpaid carers were not what you would have hoped. And although there had been some work before I became minister to try and improve the sort of records and awareness about unpaid carers through the Carers Action Plan that my predecessor as Minister of State for Social Care had done a lot of work on, that there's still sort of a lot further to go on that. So limited knowledge of who unpaid carers are. I know that at various points in the pandemic, I wrote to local authorities. I think I specifically said, make sure you contact unpaid carers, find out who the unpaid carers are in your area, and contact them to see whether they are coping. From sort of very many stories, it appears not very much of that happened, although I can understand local authorities had a lot of stuff on their plate, so maybe that's why. And that I know that unpaid carers often felt, desperately unsupported during the pandemic and really struggled. I think, in addition, and again from a conversation with unpaid carers at the time or since and reading the stories, we know a lot of people, if they were unpaid carer who lived with the person they were caring for, they would be shielding together with that person, or they would be taking a lot of steps to try and actually reduce their own risk of getting COVID so they didn't pass it to somebody. So that was the scenario for a lot of unpaid carers, as opposed to those who you're describing who are more sort of in and out, being more like a domiciliary care worker. Though, of course, again, unless somebody actually was a care worker, if they were an unpaid carer who didn't live with the person they were caring for, they would be unlikely to be doing what a domiciliary care worker does, which is visit many people in one day.
Yeah, and I take that point, but they are still nonetheless having to transport themselves from their own household, maybe via public transport or not, to the person they're caring for, go to the shops and the like. So there is a transmission risk, although I take the point, perhaps not as much as going to 10 different houses each day.
I mean, I think one of the, to the extent of silver linings, maybe, or however you should put it, that as a part of the vaccine programme, there was some success in building up the sort of register of unpaid carers amongst GPs' records. So there's some increase in awareness about who unpaid carers are, but that is work that still needs to be continued, so that in this kind of scenario or others, there's greater knowledge about who are the unpaid carers, and so that they can be offered support.
Fine. We know in due course that there was a progress update given on the rollout in May 2021. By this stage, it had become national. And again, the figures were relatively low. There's no need to put it up on screen, but it includes in Leeds 137 orders in 8 weeks only. Indeed, in Wiltshire, approximately 60 unpaid carers had requested PPE, and in Durham, 36 unpaid carers. So similar low numbers to that which the pilot had envisaged. Do you know whether there was sufficient work done to promote the rollout of free PPE to unpaid carers? You told us you wrote the letter, but did you have any other...
what channels were used to try and... I think... So this was something where we looked to local authorities who had, the social care oversight in their area, including responsibilities relating to unpaid carers. So we looked to local authorities to communicate through the channels that they had to encourage uptake of the offer.
Just finally on this, Mr. Hancock spoke of the definitional challenges in determining who is or isn't an unpaid carer. Do you have any observations on if there's any way of making it easier to identify unpaid carers, so that if in the event of a future pandemic we needed to get free PPE to them, we'd at least know who they were and then be able to communicate with them?
Yes, and this is an area of work that I did more on in my second time as Minister for Social Care. One is through GPs and their conversations with patients, whether it's the individual patient who's being cared for or indeed an unpaid carer as a patient themselves. Another route is through schools and trying to get schools to identify when you've got young carers, and there are material numbers of young people who are caring for siblings or parents. It can have a huge impact on their schooling, and there is some work was going on with schools to get schools to identify unpaid carers, and clearly local authorities where they have contacts. So I don't think there's a single answer on this, in part because not everyone will kind of necessarily recognise that they're an unpaid carer.
No. And you may be one only for a couple of weeks or for a couple of years or for a lifetime.
Long time, yeah.
All right. Can I change topic then?
Before you do so, can I say there's one more thing, and I think I put it in my lessons learned. I was just looking forward to see if I could see it, but I couldn't, which is on PPE, which is one of the conundrums for me, is in the second wave, after we had the winter plan, we know that there was a substantial supply of PPE going out to care homes. We know that there was the training in place to support staff to know how to use it effectively. We had large amounts of testing going on. We had designated settings. And despite that, we saw saw COVID get into many care homes during that second wave in the winter. And to me, there is a question which, and I asked at the time of my public health advisors, what is going on and how is it getting in there? And I think the record will show me asking questions like, is the PPE not working? And I was assured at the time, no, this is the right PPE, we have the right PPE guidance. But subsequently, there has been work done, which has particularly looked at hospitals. And why is it that more healthcare staff got sick from COVID in sort of ordinary wards, shall you say, during the pandemic, rather than intensive care, where they had a higher level of PPE? And one of the things I've seen from that research is that, arguably, the level of PPE that was being used in those everyday hospital wards and similarly in social care wasn't good enough in the light of the way COVID spread. Now, I am not a clinician, I'm not an expert on infectious diseases, but to me there is a question that should still be answered, which is actually, is this the right level of PPE for this kind of disease? And, for a future pandemic, what different sorts of potential infections might require different sorts of PPE? And if it is something which is infectious in the way that COVID was, well, actually, do you need to be looking at distributing the higher level of PPE and I recognise that could be enormously expensive and very hard to do, but that needs to be considered to look at whether you actually needed a different level of PPE for this nature of infection.
I can see her ladyship nodding, because this will echo with evidence we heard in Module 3 about the efficacy or otherwise of FFP3 masks versus the blue surgical masks. So thank you for adding that observation, Mrs. Whately. But can I come on to another way that there were efforts made to try and limit the spread of infection in care homes, and look at the attempts made to restrict staff movement? And you make the point in your statement that certainly evidence such as the Easter 6 study, which we're familiar with, showed that staff were a key vehicle of the spread of COVID-19. And indeed, by the 15th of May, the COVID-19 care home support package set out ways to try and limit movement. And the easiest way to look at that might be to show on screen your statement 587-788_39, and the bullets at the bottom go over to page 40. But this is by mid-May what the department asked care homes to try and do, to ensure members of staff work in only one care home wherever possible, to extend restrictions to agency staff under the general principle that the fewer sitting members staff work in, the better, potentially cohorting staff into COVID positive or green zones, red zones, call them what you will, recruiting staff to prevent the need for staff movement, and indeed steps such as limiting the staff public transport, and indeed potentially providing accommodation for staff who chose to stay separate from their families. And we know that accompanying this package was the Infection Control Fund, or the first set of funding of 600 million. And you say in your statement that you wrote to council leaders to accompany the publication of this package, setting out the measures that the government was taking, and asking all local authorities to review or put in place a care home support plan to be submitted by the 29th of May, which should be made public. What did you envisage the care plans would include or might say, and why were you asking for them to be made public?
So I know this time I felt like I wanted to, use the capacity and knowledge of local authorities, which is substantial, clearly, of their social care system. And I knew that some directors of adult social services and some local authorities were doing a lot with their care providers, but others I was hearing from care homes saying, we haven't heard anything from our local authority, and nothing. So I'm trying to engage or enlist sort of more consistently leaning in from local authorities. And I want a kind of cascade of we're doing the national guidance, and I want that to be an implementation of that at a local level. And I wanted to see something in writing that said how they were going to do it, because if they hadn't written down how they were going to do it, then how would I know that they had thought about how they were going to do it? And if what they wrote didn't add up, then there would be an opportunity to go back and say, Did
you ever see any local authority plans on restricting staff movement?
So I think that there was a process of scrutinising those plans, but I don't recall seeing a specific plan at that time about the restrictions of staff movement.
Was the idea behind making them public, to hopefully reassure care home residents, their loved ones, what was being done, but also to name and shame those that didn't make theirs public?
Yeah, I generally believe in making things public and transparency as a way of driving up standards. Clearly,
the bullet points that we've just looked at very much focused on the care home, and indeed the care home support package was focused on care home. But do you know, was any thought given to trying to restrict staff movement between people working in domiciliary care, and indeed a similar package for the domiciliary care sector?
I think this was I mean, I think in general the funding went to care homes and domiciliary care, and if we at some point go into the Infection Prevention Control Fund, and while the majority of that went to care homes, there was also the 25% discretion intended to go to domiciliary care, kind of reflecting the situation at the time, which was the feeling that care homes were the hardest hit and had the greatest increase of costs. But yes, domiciliary care also had an increase in costs and challenges. I do think, at this time, like the whole way through the pandemic, was as soon as we became aware about the problem of staff movement, there was a set of activities being driven from the centre to try to fix that. On the one hand, by trying to build up the workforce through our recruitment efforts, training efforts, the sort of online training, sort of free training thing that we did with trying to get people who were, say, furloughed from the hospitality sector to work in social care. So there's a strand of work to try and boost the supply of workforce. And then there's a strand of work to try and get local authorities and care providers to take the steps they need to actually take to stop having staff going between care settings, including the work that I was doing, knowing that part of that was financial, and that if you're asking somebody to not work, say, for in two different settings, different places, you're going to need to address their loss of income as a result of that. And so I'm trying to make sure that that is addressed through the funding streams.
Right. Well, I think indeed in the run-up to the package being announced, there was a deep dive at which a number of ministers, secretaries were present, and it was noted there that when discussing limiting the spread of infection, restricting staff movement was one of the ways to do that, and the financial consequences were noted for staff who was restricted. The provider sector has was reported as saying that adequate funding is a barrier to implementing the guidance more effectively. And do you think it was abundantly clear that one of the biggest barriers to restricting staff movement was the funding issue and the loss of income for those people that couldn't work across multiple homes?
So there are a couple of barriers. I mean, one was the supply of staff, where we know when we went into the pandemic that there was already challenges for social care providers to recruit and retain staff. It's quite a mixed picture. I mean, some care providers will say they have absolutely no problem recruiting and retaining staff. Others will have a high staff turnover. As a sector, it's known for high staff turnover and relatively low pay. One of the worries right at the beginning of the pandemic was that because of staff shortages, because of potentially staff being sick, because of staff being scared to work, and I have huge respect and gratefulness to staff who, despite the risks themselves, did go to work, but that was sometimes a problem as well. That would we find that there just weren't enough staff turning up to care for people who needed care, and we saw I think it was in Spain early on, examples of care homes just abandoned and people dying just because the staff didn't go into work. So the supply of staff was a very early concern, and we did work continuously through the pandemic to try and address that. As you say, even with supply, the other hand of it was funding, and going from funding into paying staff, for instance. It's across sick pay and pay for isolation, and to not do other jobs. The various mechanisms to fund the sector that I put in place were intended to solve that problem, where I didn't want money to be the barrier to stopping staff movement, and that was the intention of the policies, for sure.
Understood. So that was in May 2020. In, I think, June 2020, the Vivaldi study results became made available, and that highlighted the risk factor where bank staff were regularly used as a vector of transmission. And indeed, I think Professor Shallcross gave evidence to us at the beginning of the hearing, and she said that the survey provided evidence that care homes that did not pay full sick pay were more likely to have infections in residents and staff. And she'd reported that to the task force. And I think, can you help me? In relation to the Infection Control Fund, one of the aims was that it would pay staff full wages if they needed to isolate. The inquiry is aware that at the end of July 2020, 66% of care homes, so 2/3 were paying staff full wages, but clearly 1/3 that weren't. Do you know what efforts, if any, were made to try and ensure that the remaining third did do that which the fund was intended to do?
Yeah, I've seen that, and also I think one of the submission was it from Unison to the inquiry had some data on this of despite both the funding and the instruction going out that staff should be paid full pay for isolating because they had COVID or indeed because they were a contact. Yeah. And I think through various channels I put out pretty robust communication saying this should happen. Still, it is evident in retrospect and from that kind of data that it didn't happen. I think one of the challenges is obtaining the data that would tell us down to a care provider level where that wasn't happening. Clearly, we had the capacity tracker, and one of the things, the levers we put in place was that the capacity tracker had to be filled in order for care providers to get funding, and we had local authorities meant to be doing due diligence on the distribution of funding, but these are imperfect mechanisms. And we also had the regional team that we put in place, me and Michelle Dyson together, in order to have more outreach, in order to have people in the department who could literally pick up the phone to a care provider if we heard a problem with their sort of compliance with one of these things. But that's not the same as having a comprehensive reporting system which is giving you data as to when a staff is off sick, are they getting their full pay or not. We didn't have that kind of system.
I mentioned there Vivaldi. Can I ask you about this? Were you aware of or asked to get involved with enabling PHE and NHS digital data shared into the Vivaldi Lake Stream, which I think was held in the NHS Foundry? Do you recall being asked to put ministerial pressure on to get that data shared?
So in general, data. So the data story is that we started off with very limited data at the beginning of the pandemic. The real struggle to get even data about deaths. What felt like a battle with PHE to get them to share deaths data with me. The development of the capacity tracker, which was very useful, the work to get that completed, and then the iteration from that into the Palantir dashboard, which was a fantastic tool, which I had access to and was looking at. But it was the first thing I did in the morning when I woke up pretty much was go and check that dashboard and see what was going on, because it gave me a good early warning system as to rates of COVID in care homes, particularly once we had the testing up and running. So the data evolved. In general, other than I said that early sort of challenge with PHE trying to get death data, I don't think data was in general withheld from me. I think there might have been one problem at which I had some issue with the login, but that was an IT problem rather than anything more significant.
We may look at data a little bit this afternoon, but I was actually just trying to focus on Vivaldi data and whether you recall that you had to use some ministerial pressure to ensure that Vivaldi got the data they needed from Public Health England and NHS Digital. Does this ring any bells with you, Mrs.
No, I don't recall a problem for Vivaldi accessing data, no.
And were you ever aware that Vivaldi findings were being reported to you in secret without other people at DHSE knowing about the Vivaldi findings?
No, I don't believe so. I was given presentations of submissions about Vivaldi through the normal channels.
As far as you were made aware, were you ever alerted to a PHE or indeed the department being obstructive about either setting up Vivaldi or reporting on its findings?
No.
Can we go back to limiting or efforts to limit staff movement? And the inquiry has already heard that there were a number of proposals running from, I think, July 2020 onwards to consider whether there could be legislation brought in to to restrict staff movement. Including in July 2020, I think David Pearson, now Sir David Pearson, sent you a submission in which he noted 90% of care homes had put in place actions to restrict staff movement. And he recommended that consideration be given to legislative change. Mm-hmm. He also recommended regulation of agencies and advocated for a one-off bonus of £500 to be paid for social care workers. We'll look at legislation in a moment, but do you know if any work was done in relation to his recommendation about regulation of agencies?
I recall that staff movement restrictions were meant to apply to agency staff just as much as they would apply to sort of permanently employed staff employed directly by a care provider.
And what about the recommendation for the one-off bonus payment to be paid to social care workers? Do you know what happened with that recommendation?
Yes, I remember us discussing how the bonuses and how we could reward the care staff, but I cannot remember the outcome of that conversation, but I could potentially look it up and try and get back to you on that one.
I think in due course there wasn't any one-off bonus payment paid into the English adult social care sector, but maybe come back to that if we need to follow that up with you. Sticking with the legislation, though, I think there was a number of issues that you were concerned about. And can we have up on screen, please, INQ 109792? We are in September of 2020, and one of the options, just to help you, Mrs. Whately, was an amendment potentially to Regulation 18 of the applicable regs, which required providers to deploy enough suitably qualified and competent staff to meet the needs of their carers. It was about safe staffing levels and whether that regulation could be amended to deal with the restrictions on staff movement. And you, Secretary of State, is content for the team to address the Minister's questions below on the further detail, and you had raised the below questions. Does the capacity tracker tell us that 91% of care homes of confident staff are not moving, or that they are restricting movement, which is not the same? Did you ever get an answer to what the tracker was actually telling you?
My recollection is what the tracker told us was the latter of those things. That it was, I think that the question was whether they were restricting movement or not. And I don't think we necessarily had the answer to, therefore, whether there was
As you
no
point out there, it's
movement.
not the same as saying the staff are not moving.
Yeah.
I won't go through all of them, but the consequences of not being compliant with regulation, there was not to be prosecutions, but there could be regulatory action if Regulation 18 is not enforced. Various other points, but can we go, thank you very much, to page 3. And you raised this issue. Given the risk flagged in there may be a greater impact on women working part-time on zero hours contracts. Can we have a mitigation on this? You would prefer to see this benefiting this group of people by giving them guaranteed minimum hours, or at least in the option of guaranteed hours, should they wish, in return for the commitment to only working in one place. We're aware that there's a greater proportion of women in the adult social care sector, but can you help with what was the risk and why did you want there to be potentially a guaranteed minimum hours written into any legislation that might mandate against staff movement?
Well, because I'm thinking here about the reality of the social care workforce, which, as indicated here, often women, often from ethnic minority communities, of low pay. So you've got a group of people who, if the consequences of the policy is just loads of their income disappears, how are they going to keep paying the bills? So I want, as part of this policy, for that part of the policy to be that you make sure that people who lose out financially from the policy aren't left with not enough to live off.
Ultimately, you indicated there you were minded to go with the recommendation to take the Reg 18 route. Why were you minded to try and see if there could be legislation brought in to restrict staff movement?
Well, because from relatively early on in the pandemic, we have repeated sort of bits of evidence that tell us that where there is staff moving between multiple settings, you've got a higher risk of outbreaks. And so repeatedly at various points, we look into what can we do about this. And, by this point, we've given funding, we've put out pretty strongly worded guidance saying that staff movement needs to stop. We've got local authorities to get involved, to have plans to stop staff movement. There was one piece of evidence, I think, as part of the summer, which there was a spreadsheet that I was presented with about recent outbreaks, and every single one of those outbreaks was in a care home that still had staff movement. So to me, this is very, very serious, that all these efforts are being made, yet we've still got staff movement going on in certainly the 9% of care homes, according to the capacity tracker, that are not even restricting staff movement. But as I think I said, those who were restricting it weren't necessarily stopping it. So I'm like, well, we have to, where do we go next with this? It's legislation. That is the next lever that you've got, hence where I am in the bit you highlighted.
Yeah. Now, there was a consultation that autumn, I think, about the proposal to require the CQC registered care homes to not deploy staff if they have or have in the previous 14 days been carrying out a regulated activity. But there was an exception to that proposal that if they needed to ensure there was enough staff available to care for residents safely, then the providers could deploy this temporary exception. And I think in due course, the consultation, there was concern to you that limiting staff movement could lead to understaffing. Did you take that to mean that if there was understaffing, there would be a lower quality of care provided?
I mean, yes, the risk of understaffing is lower quality of care and potentially unsafe care. And if you don't have enough staff to look after people, then you've got somebody with dementia who may become dehydrated if they're not drinking enough, or those sorts of things. There's risk to life as a result of that. So it's very serious if you're short of staff and unsafe care. So, and to me, this was a constant battle on trying to stop staff movement versus me listening to the sector, and the sector telling me there's a risk that this will be unsafe, so you shouldn't do it.
Can I ask you about actually some of the views of the sector? Because in the middle of the consultation, you held a teleconference with a number of adult social care providers on the 17th of November. Can we have a look at INQ 328021_3? Thank you very much. And can we see their reference to Caroline Abrahams, who in fact gave evidence to the inquiry earlier this week? She was making the point on behalf of Age UK that when discussing whether to bring in restrictions on staff movement, she said, why are we pressing ahead with this when we have such promising news about a vaccine? And you sort of take those points on board. We're looking at the responses and we'll weigh up the options in light of new developments like the vaccine. However, the level of concern around this consultation is striking and makes me wonder how many staff are moving between settings. The guidance has been not to do this, except where unavoidable, for a long time, i.e. since May of that year. And then Mr. Pearson gave some observations on the Vivaldi research, showing that you're 3 times more likely to have outbreaks among staff if there is movement. And you said, I'm confident about staff levels considering the exceptions in the guidance, and then the reference again to the vaccine not being rolled out yet. So clearly there was not unanimity about whether there was the need for legislation to come in. Were there other concerns brought to your attention, perhaps that were unrelated to potential vaccines? Clearly, safety of the residents was one.
I mean, I think it summed up quite well here. I mean, Caroline Abrams is somebody who's extremely well informed and would respect her view there. And that sets out this dilemma between, I'd say, unsafe staffing versus the very substantial risk, as David Pearson says there, that there's a materially greater likelihood of an outbreak if there's staff movement going on. The vaccine was on the way, but it wasn't there yet, and we didn't know how long it would take to roll it out. And as I think by this point, I am extremely frustrated that the evidence is so clear of the risk of staff movement. The money's been going out there. Why is it still going on? And as I say here, if we'd done the legislation, there were still exceptions in the guidance, which would mean that if you felt you couldn't provide safe care without some staff movement, it's still would enable it.
All right. Just standing back for a moment, we know in due course that it wasn't possible to bring in legislation. You set out in your statement that you argued that the staff movement restrictions should be accompanied by furlough payments and or some kind of other financial support to compensate for loss of earnings, but make the point, obviously, that would require Treasury approval. And indeed, Treasury rejected the proposals to compensate staff. Just standing back for a moment, Mrs. Whately, what do you think now about whether there should be legislation and or funding and or anything else that might help ameliorate the risks that staff might unwittingly transfer COVID into care homes in the event that there was a pandemic which struck care homes in the way that this one did?
So I think for a future pandemic where it's similar to this or these kind of scenarios, you need to have a plan by which you can stop staff moving between settings, because here it was clearly a material risk factor. You could have an even more infectious pathogen where it was an even greater risk factor. So you would need to have a plan to enable you to do that. Clearly, the biggest challenge was about the supply of staff. You need to both be able to make up for the incomes of those who lose income because of that, and so you need a system for doing that. And you need to have a greater supply of staff. And what was evident is that we set up a bunch of things to increase supply of staff and recruitment and bringing people across from other sectors, but that was insufficient. So a future pandemic plan will need to work out how do you find a way to ramp up staffing further, recognising that while clearly social care requires material skills, and that's something that experienced care workers bring to their work, it is something where you can train and support somebody to be able to play a material part in a team, particularly in a sort of setting like a care home where you've got multiple members of staff around. So it should be possible to boost the supply, but I think that is something that would be worthy of advanced thinking. And the other thing is to build up the workforce in peacetime, so to speak, which is something that I spent significant time doing as my time as social care minister, and developing what's called the care workforce career pathway, which is about exactly that, making it worthwhile working in care so that people would pursue a career in care. And also the work that I was doing to get CQC to assess local authorities, and part of that assessment looks at how they commission care, and part of that assessment is meant to look at whether they commission care in a way that means that care providers are employing staff on proper contracts with decent hours and decent pay and sick pay and all of those things. So looking at it through the commissioning route. These are things which I kicked off as part of the reforms when I was a care minister to try and put us in a better place in a future pandemic.
Yeah, understood. Can I ask about one discrete area, which was the designated settings policy, which was another way to try and prevent COVID entering the care homes. And we're aware that each local authority was to identify sufficient accommodation to be able to care for COVID-19 positive patients being discharged from hospital, and the designated settings were identified. And it dealt with this at your paragraphs 132 in your statement, if that helps you, Mrs. Whately. But you know that the inquiries asked you specifically why the designated settings guidance wasn't introduced earlier in the pandemic and why there was an apparent delay in implementing it. Can you help us with those observations, please?
Yes, I mean, to some extent we may end up covering a bit of the territory we covered in the earlier conversation about discharge, but the plan and the policy in the early part of the pandemic, was it from the mid-April discharge guidance, was that local authorities would set up essentially what became formally known as a designated setting to accommodate and care for people discharged from hospital when the care home that they were due to go to wasn't able to effectively isolate and care for them. So that was what was agreed in April as the approach, and my understanding was that that was something that local authorities were doing. So that was the policy. Then in the period through the summer when the COVID rates went down and we set up the Adult Social Care Task Force led by Sir David Pearson, the objective of that task force was to say, what can we possibly do to help protect care homes and social care more broadly for the coming winter in the event that there is another wave of COVID, as indeed there was? What can we possibly put in place? And one of the things that came out of that, and as we were preparing, therefore, for the next winter, was having a more robust policy on this designated settings, on having a place to discharge people from hospital. And as in the record shows, a policy that we then put in place, it did involve a lot of work. So, material, man hours put into setting up this policy so that it could really properly work and be overseen from the centre.
Yeah, we understand in your statement you set out the efforts that CQC made to ensure that the designated settings were appropriate. Do I take it that you were therefore in favour of the designated settings policy?
Yes.
And would you still be in favour of having it or an equivalent thereof in the event of a future pandemic?
Yes, clearly we have to always be careful not preparing for the last pandemic, but whatever it might be. So you need to prepare for a range of scenarios. But I think, one of the scenarios is, definitely from the experience that we went through with this is, okay, so if the NHS again needs to free up beds, and you don't want to discharge people into care homes, well, where are you going to discharge them instead? And it took some, multiple weeks, even months, to, and still done pretty quickly, to identify and set up and create some designated settings that could do that. So much better to have them ready from the moment it looks like a pandemic is on the horizon, to be able to do that and to operate them preemptively. You also might find a scenario where if you've got a highly infectious pathogen and you believe somebody within a residential care setting has got that, you might decide you want to move them out of the care setting rather than try and care for them within it. Now, we know moving people who are frail and elderly particularly is difficult to do and can be a risk to their own life indeed. However, you would be weighing that up versus what we see is something can go through a care home very quickly, and it's very hard to quarantine within a care home setting. So you might want designated settings to do that as well.
Yeah, I was going to ask you about that because Dame Jenny Harries gave evidence to the chair, and she made the observation that there is a risk with the designated settings policy, not only now putting all of the infected people into one area, but equally the point you've just made that moving the elderly and the frail increases their mortality. Never mind the effect of isolating potentially in a wholly new setting that is alien to them. Were these counter-arguments put to you when you were devising the designated settings policy? And do they in any way change your view that you would still have one potentially in the event of a future pandemic?
I remember having discussions about that back at the April time when we were looking at the discharge process and whether somebody should be discharged from acute hospital to NHS step down, which then proved not where we ended up on the way to the care home, of that risk of moving somebody in an unfamiliar environment, particularly somebody, say, frail with dementia. So I think that is a recognised risk. These are exactly the sort of risks that have to be weighed up. The risk to an individual of being in an unfamiliar setting and multiple moves versus if something's highly infectious and if you can't isolate somebody within a care home effectively, but you might have a care home with 10, 20, 50, 100, however many people in it. If bringing somebody into that scenario who's infectious then means that everybody in that setting is going to get a potentially deadly illness, these are the things, the difficult decisions that would have to be made.
I'll deal with one other topic perhaps before we take a lunch break. And you mentioned their preparations for another wave, and we know that there was particularly severe outbreaks in December into January 2021. And I think in January 2021, you received reports of care home staff continuing to work even after they tested positive for COVID-19. And I'm at your paragraph 172.
Thank you.
You asked for the matter to be investigated, And can we show up on screen, please, INQ 565732, which is a draft letter, but we know that the draft did in fact go to you, but helps summarise the position. We are here at the 22nd of January 2021. It's a note that Miss Dyson was preparing for you and indeed for Mr. Hancock, and it was to alert you to the problem. And as at January 21, you're aware of 6 cases. 2 of the cases are in care homes, and 1 involves a care home in an area with a significant number of deaths that had been reported. They were letting you know that there was 1 case early in January which was discussed, and at that time it was believed to be a rogue case. But now that regional assurance teams had found a further 5 cases, making the 6 in total, it appears that in some cases the action has been signed off at a local level on the grounds there is a risk to safe staffing without the COVID positive staff continuing to work. A number of further requests have been made to our regional assurance team which have been turned down. So it is clear that we have a systemic risk. Was that a request to allow positive staff to continue working that was turned down by the assurance team?
It looks like it, though in general, so when it says at a local level it had been signed off, that wasn't a sign-off by the regional assurance team, because our regional team would not have signed off anyone to do COVID positive working, but that's implied by that sentence.
No, Ms Dyson told us yesterday that there was never any departmental policy that it was acceptable to work in COVID positive when COVID positive at all.
Correct.
And I see your vehement agreements with that. Indeed, you then highlighted the problem to Mr Hancock in a WhatsApp, describing it as note coming your way, we positive staff working in care homes, shocking and totally unacceptable. We would not have known this if we hadn't set up the regional assurance team. And then, in fact, the numbers grew to 50 by the 10th of February and at least 94 by the 13th of April. Again, I hesitate to use the word justification, but the reason given was because without the COVID positive staff working, there would be a risk to providing the care for the residents. Do you know if it was even more widespread than the 94 by April 2021?
I don't have any data to indicate that it was more widespread, but I think you've effectively expressed I was shocked and not furious to see this happening. And I still find myself looking at it going, how was it completely impossible to find some staff who weren't COVID positive to cover those gaps? I still find that surprising and shocking.
Do you know if this was an issue with COVID positive working across domiciliary care?
I don't have that data.
Did you hear any reports of it happening on the domiciliary care side of?
No, I mean the only reports I have are the things that you have referred to there, and I said I think that was in care homes.
Right. Did you ask for any investigation to be carried out as to whether there was any link between the COVID positive staff and either an infection outbreak or worse still a death in the care home?
I mean I asked these situations to be generally investigated, and I know that the police were involved in at least one occasion.
Yeah, indeed. I think the CQC were asked to get involved, and potentially the police were asked to get involved. Were you asked to put out any kind of statement or public announcement decrying the use of COVID positive staff?
I think we did. I feel like I recall having conversations saying, how can we get this message out very loud and clear that this is completely unacceptable? Although I don't have in front of me what routes of communication we then did for that, but that was part of the conversation.
Right. My lady, would that be a convenient place to stop? So I'm moving on to a different topic.
Certainly, and I understand that it would be convenient to have a slightly longer lunch today, is that right?
Yes, if possible, thank you.
Actually, sorry.
I shall return at 2:00.
Thank you very much.